Hi friends, hope you are all safe in this Omicron COVID time. Today I will give you a snapshot of latest sepsis guidelines, which is a must-to-know topic for all of us. So far, 5 sets of guidelines have been published in last 2 decades time. It all started in 2004 when Surviving Sepsis Campaign published its first guideline regarding the management of severe sepsis and septic shock. In 2008, second came. In 2012, 2016, and now we have fifth one, 2021. Every time it was improved, refined, and crystallized by a union of researchers, scientists, and finest of critical care experts from all over the world. The guidelines provide recommendations on the management of sepsis. The 2021 guidelines largely apply to high resource settings, but discuss the applicability of the recommendations to lower resource settings as well, and that is unique about this. The guidelines recognize sepsis as life-threatening organ dysfunction secondary to a dysregulated host response to infection, consistent with Sepsis 3 consensus definition, which was published in 2016. Guidelines questions were assigned to one of the 6 SSC adult guidelines working groups: screening and initial resuscitation, infection, hemodynamics, ventilation, additional therapies, and goals of care and long-term outcomes. So in a way, this guideline is quite structured. Now let's sail through SFC's 2021 guideline. So the first section is the screening and initial resuscitation. So regarding the sepsis screening and treatment, the recommendation in previous guideline about the performance improvement program was just a statement, and with continued accumulation of research, in last 5 years in this area, the quality of evidence is now moderate in 2021. So what are the performance improvement program? One example is the introduction and implementation of this 1 hour bundle, which was published in 2018. We all know QSOFA, right? However, there is no mention of QSOFA in 2016 guideline, and a plethora of research has been conducted in the last 5 years. The results have been contradictory to its usefulness. A meta-analysis of 10 studies showed that SIRS was significantly superior to QSOFA for sepsis diagnosis, and QSOFA was slightly better than SIRS in predicting hospital mortality. The association of both criteria could provide a better model to initiate or escalate therapy in patients with sepsis. Therefore, this guideline recommends against the use of QSOFA compared with other screening tools such as SIRS, NEWS, or MUSE. However, machine learning may improve performance of the screening tool as suggested in this guideline. Machine learning outperforms compared to traditional tool according to this meta-analysis. Lactate measurement is still suggested within 1 hour of detection of sepsis. Lactate clearance should be targeted while you resuscitate the patient. The panel downgraded the recommendation regarding the initial fluid resuscitation. In 2021, the recommendation is weak now, and there is low quality of evidence. There are no prospective intervention studies comparing different volumes for initial resuscitation sepsis septic shock. The average volume of fluid received in pre-randomization, the process, promise, and ARISE trial was in the range of 30 ml per kg, suggesting this fluid volume has been adopted in routine clinical practice. Similar to previous guideline, this guideline also suggests to use the dynamic measure of fluid resuscitation compared to the physical examination. A new recommendation in this guideline is made about the use of capillary refill time to guide resuscitation. The Andromeda shock study on 424 patients demonstrated that a resuscitation strategy targeting normalization of capillary refill time compared with a strategy targeting serum lactate level did not reduce all-cause 28-day mortality. CRT estimation is rapid, reliable, and inexpensive compared to lactate measurement, and that is the reason this guideline has taken this recommendation on CRT. Regarding the mean arterial pressure, 2016 guideline clearly said the target should be 65 or more than that. However, higher target more than 85 in chronic hypertension and elderly was also advocated in the previous guideline. However, in this guideline, it made clear that there is no advantage of keeping higher MAP target. Recently, 65 trial compared a permissive hypotension, that is MAP 60 to 65 millimeter of mercury group, with a usual care group in patients aged more than 65 and older with septic shock. And they found that 90-day mortality in permissive hypotension and usual care group was similar. Delayed admission of critically ill patients from emergency department are associated with decreased sepsis bundle compliance and increased mortality, ventilation duration, and ICU hospital length of stay. Therefore, guidelines suggest to admit sepsis patient within 6 hours, and this is a new recommendation. This guideline also stratify antimicrobial timing recommendation based on likelihood of sepsis and presence of shock. This is just to prevent antimicrobial overuse. In case you are sure of sepsis, administer antibiotics within 1 hour as soon as possible. However, if sepsis is just a possibility, you are uncertain. In this case, there are two scenarios. If there is shock, you administer the antibiotics immediately within 1 hour. If there is no shock, take some time to think, to assess, to reassess the patient. And if the concern regarding the infection persists, administer the antibiotics in about 3 hours. And that is the change in the timing was done to curb the antibiotic resistance, which is quite a prevalent problem nowadays. Like 2016 guideline, there is a weak recommendation against using procalcitonin to guide antimicrobial initiation in addition to clinical evaluation because there is no apparent benefit, unknown cost, and limited availability in some settings, including low and middle income countries. Regarding the antimicrobial choice, these guidelines give clear recommendation for using empirical coverage for MRSA, gram-negative, multiple drug-resistant organisms, and fungal infections if there are certain risk factors are present regarding that particular infection. The 2021 guidelines provide no recommendation for antiviral. If you are using beta-lactams, infuse them in the form of infusion. Source control is very important, and remove device if it is the cause of sepsis. Daily assess the de-escalation of antibiotics while you are on round, and keep the antimicrobial therapy as short as possible. For the purpose of stopping the antibiotics, procalcitonin and clinical evaluation is still suggested by 2021 guideline compared to 2016 one. There are many increasingly recognized potential adverse effects of normal saline, including hyperchloremic metabolic acidosis and also the development of acute kidney injury. In the 2018 SMART Single Center Cluster Randomized RCT, patients admitted with sepsis experienced lower 30-day mortality when randomized to balanced fluid versus saline, and that is the reason 2021 recommendation preferred to use balanced salt solution compared to normal saline. Regarding the colloid administration, guidelines do not suggest to use these starches or gelatins. However, albumin administration is still suggested to be used when patient has already received a large amount of crystalloid. Regarding the choice of vasopressor, NORAD is first choice, followed by dopamine and vasopressin in case of unavailability. If you want to add a second vasopressor, if MAP is not maintained, consider vasopressin as a second choice. The third choice could be adrenaline if MAP is still not maintained according to guidelines. In case of cardiac dysfunction, you have to add the dobutamine or epinephrine, whichever is available. However, guidelines suggest against levosimendan use. A meta-analysis of 7 RCT comparing levosimendan with dobutamine showed that levosimendan was not superior to dobutamine in adults with sepsis in terms of mortality. Regarding the invasive arterial blood pressure monitoring, 2021 guideline suggests to use it to better titrate the vasopressor doses. Though liberal fluids during septic shock has been shown to be deleterious, but evidence is still underpowered, and therefore guidelines 2021 guideline says that there is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies, and the ongoing trials like Clovers and Classic will shed some light on this matter. Regarding the high flow nasal cannula, there was no recommendation or suggestion in the previous guideline. Present guideline suggests to use it over NIV for the patients with sepsis-induced hypoxemic respiratory failure. The evidence profile is based on single RCT comparing HFNC versus NIV, and that was the Plurali trial. The guidelines recommend a low tidal volume ventilation strategy with limitation of plateau pressure less than 25 for patients with sepsis-induced ARDS, and a use of prone positioning in moderate to severe ARDS. They suggest using traditional recruitment maneuver but recommend against an incremental PEEP strategy. There was insufficient evidence to make a recommendation regarding the use of liberal versus conservative oxygen targets, and this remains an area for future research. A 2017 single center before and after study reported reduced mortality with high dose vitamin C, but an updated meta-analysis by the guideline panel found no association between vitamin C and reduced mortality, and therefore 2021 panel recommend against using vitamin C. There is upgradation of recommendation for the use of steroid in septic shock. Now, guidelines suggest to use it if patient is on ongoing vasopressor therapy. An updated meta-analysis found that systemic corticosteroid can accelerate the resolution of shock and can increase the vasopressor free days, and therefore now the overall quality of evidence is moderate. What about the blood purification strategies such as cytokine filters? 2016 guideline made no recommendation. However, 2021 is strictly suggesting not to use polymyxin B hemoperfusion because frequency of undesirable effects is reported in few trials, and in addition to that, it is expensive, resource intensive, potentially reducing the health quality of patient, and is quite infeasible in low-income countries. There is no change in recommending the ulcer and DVT prophylaxis in this guideline. However, regarding DVT prophylaxis, 2021 guidelines suggest against using both pharmacological and mechanical thromboprophylaxis. If for some reason you cannot use Clexane or low molecular weight heparin, put the patient on DVT pump. Dialysis needs to be initiated in septic AKI as suggested by this guideline. Hyperglycemia is associated with higher mortality, therefore insulin is recommended if glucose is more than 180 mg per deciliter. Based on a new RCT bicar ICU trial, guidelines suggested that bicarbonate should not be administered in lactic acidemia to improve the hemodynamics. Rather, they suggest to give it in septic AKI if pH is less than 7.2. So I think that's quite clear. If tolerated and feasible in septic patient, enteral feeding should be commenced within 72 hours in critically ill patient who is having sepsis. No recommendation regarding the parenteral nutrition has been made in this guideline. Patients who survive a protracted period of ICU care for sepsis typically face a long and complicated road to recovery. Therefore, panel recommends discussing goals of care and prognosis with patients and families, and that too early. There is no standard protocol suggesting for such discussion. Panel identifies the role of palliative care in patients with sepsis who are not responding to treatment, and therefore recommend integrating principles of palliative care into treatment plan judiciously. This guideline also highlights the importance of sepsis education for septic patient and their family. The sepsis education may be given in the form of written or verbal forms prior to hospital discharge and in follow-up settings. The current guideline uniquely suggests using a handoff process of critically important information at shift changes to maintain the continuum of care. However, any structural format of handover can be adopted for this purpose, and guideline does not tell about a specific type of or structure of this handover. Shared decision making is a process in which health professionals, patients, and their caregivers, family collaborate in making the decisions about the patient's care options. And this guideline give the recommendation regarding this. Cognitive impairment after critical illness is common and debilitating. Many studies have been performed to see the role of various cognitive therapies in ICU. However, panel does not make any recommendations to use any kind of cognitive therapy. These guidelines are unique in focusing the recommendations on ICU follow-up of sepsis survivors. They suggest to use a post-critical illness follow-up program if available, and also suggest to refer a patient who received mechanical ventilation for more than 48 hours or ICU stay for more than 3 days to a rehabilitation program or rehabilitation consultant. This executive summary highlights the most novel aspect of surviving sepsis campaign international guidelines. We believe that 2021 SSC guidelines will foster the delivery of best practices for sepsis evaluation and management. There are very few strong recommendations. More areas of research have been identified. This guideline is unique because it can be applicable even in low resource setting. It focuses on post-ICU discharge planning and long-term follow-up. And with this, I conclude my presentation. I hope that you must have got salient points from this guideline. And I hope by utilizing these points, you can improve the sepsis care in your critically ill patient. So thank you so much for your attention.